Welcome to First Star Let's Chat, an athletic therapy podcast. I'm your host, James Gardner, certified athletic therapist, certified strength and conditioning specialist, yoga instructor, human being. This platform, for the pros, by the pros, anybody in the performance space, and beyond. Welcome here to share in the stories of professionals, experiences, journeys, learning along the way. It's a platform to connect, to network, and to be a part of a community that cares, with conversations that matter, experiences that resonate, and generate ideas, thought-provoking, organic dialogue, passionate pros. Brought to you as always by First Star Therapy, Mobility Tape, Epic, and Benchmark Athletics, in association with the Canadian Athletic Therapists Association. It's First Star Let's Chat, an athletic therapy podcast. Thanks for being here. Thank you for being a part of it. And we are off and rolling. It's Let's Chat. This is session 144. Humbled, honored to have Cindy Trowbridge as our guest today. We'll get into her bio. Thank you, Cindy, for making time for being here today, here in Texas, out at the University of Texas at Arlington. Cindy was recently inducted into the Southwest Athletic Trainers Association Hall of Fame in July. So congratulations on that, an honor obviously deserved, but haven't had the opportunity to say it in person. So congratulations. And that adds to your fame, I guess, in the profession of athletic training, as you were awarded the NATA Foundation Lifetime Achievement Award in 2022 as well. So an esteemed athletic trainer south of the border here from Canada. Cindy has been a certified athletic trainer since 1993 and has worked in clinical, educational, and research settings. She's been at the University of Texas, Arlington since 2004 and has served in both the MSAT program and the exercise science program. She's had the opportunity to be involved with the United States Olympic Committee, has traveled internationally with bobsled and skeleton teams, plus served on the sport medicine teams for the Winter World University Games in 2003 and the Beijing Paralympics in 2008, also serving with USA Basketball. Cindy, welcome aboard. For the purposes of our discussion for our audience and myself learning from you, the expert in this, we'll lean into your expertise as Cindy has investigated or continues to investigate the clinical effectiveness of a variety of therapeutic modalities. So thank you once again for being here. Congratulations. I hope this opens our audience to you and all the things that you're doing, and you potentially to some of our audience as well that's out there listening as we move forward.
Great. Thank you, James. It's such a pleasure to be here. James and I got to meet at the WFAT in Israel. 2 years now, I think. Yeah, it flew by that time frame, and got to participate in the Let's Chat with some academic questions and issues. And so we've been talking about this for over a year, as we ought to get together and chat about modalities. And so I appreciate you taking the time to have me on, and for me to opine. I'm going to say that I certainly am not the expert, but I am, one of the people who had the pleasure to study with Dr. Ken Knight and Dr. David Draper. And so I grew up in athletic training education around Dr. Cold and Dr. Heat or whatnot, because of Ken Knight's work in cryotherapy and David Draper's work in ultrasound and diathermy. So a unique background that has really wanted me to always talk about modalities as an adjunct to care and not as a solo of care. And it's just really important as we approach this, that you always think that a modality is a therapeutic intervention, just as much as exercise is, just as much as sleep is, just as much as nutrition, stress management. They're all therapeutic interventions that are designed to kind of decrease disability and increase functionality with that. And so one of the things I've tried to remind students is that there are no perfect therapeutic modalities. There are only patients. I have a series of students who call them Dr. Trowbridgeisms, and they'll sometimes jokingly post them different things. But once again, there are no perfect therapeutic modalities. There are only patients. And we have to address the actual pathology that we're trying to treat, set a goal, and then match that therapeutic modality to our clinical goal. If we're not doing that, then we're just throwing darts at a dartboard. And not playing a particular game, not playing cricket or, whatever you want to play. And so we have to think about that possibly modalities haven't worked very well for many people because they're not matching the therapeutic modality with the clinical pathology and with the goal. And that means several things. I like to have 4 different things that I oftentimes say. I can say you can have the right modality. So meaning it's the right modality to address the pathology and potentially the goal. And you apply it at the right time because there's a window of opportunity, which the tissue needs a certain push or maybe a pull or maybe a stop doing that tissue. So we also have to apply it at the right dosage too. So there's the actual modality, and then there's the window of opportunity or the timing, and then there's the dosage being correct. 5 minutes, 10 minutes, do I turn it up to where it's causing a muscle contraction or just have it pins and needles? Dosage is really key. There's also the right modality, but the wrong window of opportunity or the wrong dosage. All right. So it could be a good modality, but you're just applying it incorrectly. Of course, on the other end of that, there's the flat out wrong modality. And technically you're like, well, could you really have a wrong modality applied at the right window and the dosage? Well, theoretically you could, and I guess the way to say that is that, you used heat instead of ice when you were in a very acute inflammatory phase. So technically speaking, you applied the heat the correct way, dosage wise, and with an intent, but it was just the wrong modality. And of course you can have the last and final one is the wrong modality. It's the wrong window and the wrong dosage in there. But remembering that it's not really that simple. And that's an important aspect. And I also like to kind of pair it because I like this because I'm a big, I love a good beer, and you got to pair your beer with your burger or or your chicken. And then I like wine, and I just went to a wine and chocolate pairing out at a local winery here, and that was fun. Crisp cheese pairing, and it was fun to learn like the different varietals, and it just again brought back that sense that the wrong wine with the right chocolate makes for a mouth that's like, you had to have that right chocolate, 61% cocoa, and that right red wine that had a certain amount of berries and acidity. And then you're like, wow, that really, has a flavor. So I think sometimes we don't take it seriously enough. And unfortunately, many times it's like, oh, you're in pain, go get in the ice, go get an ice pack, or, walk in the athletic training facility, therapeutic room, and everybody starts with a hot pack on whatever muscle group. Well, again, maybe there's nothing wrong with that, but maybe that's been the problem all along. And I think that it's really important to emphasize, and I have to say this, that exercise-based strategies and sleep hygiene and nutrition are really the only thing that's going to get you better, all right? Modalities, in my opinion, as much as I study them, are just going to spice the pot up a little bit, are going to maybe make that exercise have an effect a little bit sooner or be a little bit more effective because now the tissue's hot and now I can stretch it a little bit better. Or pain was limiting my motion, so I used a little bit of cryotherapy or cryo spray to be able to get them to move it through a range of motion, because ultimately, and I say this to my friends all the time, motion is lotion. If you don't move it, then you're not using it. If you don't use it, you'll lose it. Motion is lotion. And so we must focus on exercise-based interventions. And those exercise-based interventions should not only focus on whatever the structural pathology is, a torn Achilles tendon, but it has to focus on the functional pathology. What made them tear their Achilles tendon? A weak glute? hyperlordosis, transverse abdominis that they can't contract and maintain core stability, shoes that they shouldn't have been in, not warming up properly. There's lots of pieces to that. And so there are no simple answers. So that's kind of my shtick that I talk about to try to get people to start thinking.
Yeah, no, and an amazing intro that brings me to about a million places that I want to go. But I guess my first ask is like, have you been able to take that saying of motion is lotion and put it into an actual bottle that can be applied? Because feels like this is the world of modalities we live in, right? Where it's like, what's the fastest path with the least resistance to give me the thing so I'm miraculously better? Like, is that out there? Yeah, right. Like this seems to be the
I think if
mentality.
there was a modality that's out there, it really is manual modalities and manual therapies that promote motion. But then again, a lot of things prevent us from moving. Tissue stiffness is clearly one of them, scar tissue, blah, blah. But pain and understanding pain, and that's one of the things that I don't think that athletic training students necessarily get enough of. I tried to spend time on that, and I tried to really help them to understand that pain is weird. And, we can't just do, 1 to 10, what's your pain at? We might want to think about having scales. And I actually just did talk about this in a class that not only has smiley faces, but has colors and has numbers and has words on it. That way, when you look at that pain scale, you're seeing a very happy face with a 0 and the color purple, and it says, I have no pain at all. I'm happy. And then you get up to the 10 and you've got the crying face. Right. And it says 10 and it's bright red and it says, I'm in so much pain, I can barely live my life. I can't toilet. Other things are really, really affecting me, because I think one of the key things to understand that pain is just an opinion. Pain does not originate from the bodily tissues. That signal that's being sent from the bodily tissues is chemicals and hormones and other things. It's how the brain interprets it. Right. If you're ever interested to Dr. Lorimer Moseley, Lorimer Moseley, is an Australian physio. And he's a neurophysiologist in particularly, and he's written a couple textbooks on explaining pain. He sponsors the website Tame the Beast, which is about chronic pain. And his message is pain's in your brain. All right. And yes, we need to protect the body part, and pain does serve a warning message. But once you're apparently healthy and not at risk of burning, of tearing the ligament any further, then pain's a nuisance. And we need to learn how to manage it, whether that be at the site where they're experiencing it, although we have to understand that pain's being processed by the brain. So what we need to change is what the brain is either receiving or how the brain is processing that. And that's really what limits people's motion. And so if I could put motion as lotion in a bottle, I would. But the thing that makes people not do their home exercise program, it hurts when I do that. And I don't know what, to do. Or, I don't know, if it hurts, then I must be hurting the tissue. Well, maybe, but also maybe not. Mm-hmm. And Lorimer Moseley has a personal story where he experienced a snake bite in Australia. So imagine that, the third most deadliest snake. He survives after a coma of a few days. And initially, when the snake bit him, it's a very small snake, he thought a twig had scratched his leg. So he just kept on walking out in the bush. And then next thing he remembers is days later in the hospital. But then fast forward a year, he's out walking in the bush and a twig scratches his leg and he freaks out. Writhing in pain, falls to the ground, thinks that this is the second time. Pain is in your brain. And a lot of times our pain mechanisms become overprotective. And so in addition to treating the tissue where we need healing, where a modality may actually really help the tissue, we have to understand that the actual pain signals, they might be emanating from that due to chemical and biological and physiological processes, but pain is a biopsychosocial construct. And so 2/3 of the equation is psychosocial. And so there's a lot to be understood in that area. And in his area of chronic pain is really helping you to understand that your nervous system really does have plasticity. It really can change, and you can change how you interpret pain and learn to move around in certain ways. So that's kind of an aside that relative to that bottle of motion is lotion. So
yes, but a critical one that obviously, like anybody who's using therapeutic modalities, anybody who's in this space of performance needs to understand at least part of that. It's obviously layered and it's multifaceted, and if I can be a part of it, then I'm going to be a part of the parts that I understand.
right.
I should have a referral network that I can utilize for the
Yes,
psychosocial elements, life historical factors,
absolutely.
relationships with pain. All of these things are maybe outside of our scope as a primary focus, but we at least need to touch on it and understand it.
Yes.
I think I've used the sentence a couple times, and again, not maybe in my most caring times or my least caring times. I'm trying to navigate it, but with patience, where I said, like, your pain doesn't bother me at all, right? Like, as a therapist, it doesn't bother me at all. So we're going to push a little bit, but we're going to push within reason. We're going to understand,
Yeah,
is
no, I
there
mean,
pain,
talking
right?
to them, explaining pain, and that's really what Lorna Mosley's about, is explaining to them that you can be in incredible pain, but not incredible danger, and helping them to understand when it's okay to push and when it's not okay to push through different parts, and that, being able to use modalities appropriately, because there are several modalities that really can reduce pain if they're used correctly. And I think that that's one size does not fit all.
This
One
is the
size does
capture.
not fit all.
That's it. There is no one modality out there, and
There's no
I
one
won't put, yeah.
modality, nor is there one type of one modality, meaning that the only thing you should use with ice is an ice cup, right? Or
Right.
heat is a hydroculator pack. There's no one size. And my best analogy to that is the nursery story Goldilocks, how she goes into the house and she's like, too hot, too cold, just right. And in each of the things, but each of the bears also had their Papa liked it hot.
Right.
Mama liked it just right. Baby liked it cold. That we have to respect that to blatantly just tell everybody, go ice for 30 minutes.
Mm-hmm. Mm-hmm. Mm-hmm.
I don't entirely know where that came from, but I certainly was brought up on that and believed that that's what you needed. But what's your goal? Is 30 minutes too little? Is it too much? What's our situation with um, understanding? Because again, there is the right modality, but there is the window of opportunity, and then there's the dosage of how much of that modality that you're using. And so I think that and most recently within the last about, gosh, it's hard to believe it's 2025, honestly. So it seems like probably 2015, maybe even like 2012, is kind of when the peace and love came out of some physios really wanted to emphasize that we needed to get rid of PRICE, PRICE, protection, rest, ice, compression, and elevation, and we needed a lot of peace and love. P is protection, E is education, A is avoiding anti-inflammatories. All right, we'll get back to that, but they put avoid icing, and I'm like, well, wait a second, time out. Ice is cheap and it's a great pain reliever. All right. C was compression. I think E then again was exercise. And then they talk about love being load, optimism, vascularization, making sure you're doing cardio outside of the, the injured part. And then I'm probably like E, empathy, maybe, I'm not sure, like with that, but that they wanted you to avoid anything that was an anti-inflammatory, because we need inflammation. Yes, we need inflammation. But never in my lifetime have I ever been able to put a bag of ice on somebody and stop metabolism. It's
This is
just
great.
not
Yeah.
possible.
Right. This is a great point. This
It's
is
not
more, a
possible.
little bit more dynamic than that on a cellular level. Yeah.
Yeah, it's not possible. 30 minutes, and the coldest I ever got somebody, and to preface this, how does she know how cold? Well, I stick thermocouples in people's muscles. So I stick temperature sensors in people's muscles, and then I put different ice, heat, diathermy, other things, and I measure temperature decreases or temperature increases. And I was using a game ready unit on a thigh of a pretty thin, I'd say we'll just call him cross-country-ish young man, just in terms of you can picture that. It's pretty low body fat, good muscle tone. And he's got the whole thigh sleeve on with what I would call your chunky ice water. So that's probably 2-3 degrees Celsius, in there, because you've got like, as I tell these students, it looks like a bowl of cereal. That was what was in the game ready cooler. And then we had it on a high compression that only goes up to 55 millimeters of mercury. And it oscillates, as you know, it usually does about a minute to build up and then a minute or 2 minutes to go back down. And then the ice just continuously circulates. Well, we did a 30-minute session with both ice and compression. And then we left the pad on, but turned off the pressure and the circulating ice. So the pad was still cold, if that makes sense, but there was no further circulation of ice in there. Let him sit for 30 minutes, turned it back on, because we wanted to see if we could get him really cold and if we could change vasoconstriction, not only in that limb, but we were measuring the femoral artery in the other limb to see with a Doppler ultrasound to see if that was vasoconstricted. Because when you're cold,
Right.
you and so then we did another 30 minutes with the compression and the ice, and then another 30 minutes of him just sitting there. He really started to shiver towards the end of the second 30 minutes, and his muscle temperature was about 21 degrees Celsius. So you start around 35 degrees Celsius. That's kind of close to about where muscle temperature is, not quite core temperature, but it's warm. But you're not going to stop metabolism until you're well below 15 degrees Celsius. So we didn't stop circulation. He still had blood flow. He still had, there no way were we stopping any processes. What we were doing is we were slowing down the metabolism and slowing down his body's response to things. We have to remember inflammation is important, but we innately respond with way too much inflammation for a closed orthopedic injury. Our body responds as if we just got exposed to the most virulent bacteria because it has an innate response. It has to respond with the fire truck, the ambulance, and the chief, right? And you've seen that sometimes, everybody comes and then they realize, well, not only do we not need the fire truck or the hose truck or the chief, we may not even need the ambulance, because they're choosing not to be transported. But that's when you call 911, they send them all, don't they? At least they do. A lot of times down here in Texas, because they all have first aid training and they all have the ability to mitigate situations. But ultimately, how much response did you need? Well, all I needed was the ambulance because, yeah, they are going to have to be splinted. It's a femur fracture. We are going to have to transport them. But we didn't need the hose truck, the squad, the rescue squad, and the chief.
Right. I love the analogy.
Yeah, but that's how our body responds. And then it allows us to kind of take stock. So this is where avoiding icing, and I did find another article from about a few years ago, and they're like, well, maybe it's okay to ice in the first 6 hours of an injury, but then after that, you shouldn't ice. And I'm like, well, once again, what are the clinical signs and symptoms that would make you continue to ice? Because if I'm still red hot and actively swelling at 6.5 hours post-injury, well, good gosh, I'm going to ice. Because that is going to tamp down and not shut down, but tamp down. But I'm also going to do other things, because it's not just cryotherapy.
And the relationship with patient as well, right? It's like, do they like it? If they like it, it's
do they like it?
advantage,
Exactly.
right?
Because if they like it, keep using it. I tell people that all the time, is that unless you are fully wasting your time and you're not getting on to things that you need to do exercise wise and billing wise, and everything, if they like it, let them keep using it. That's such an important part in there. But, again, maybe we just have to think about it differently. And one of my points is that, all right, well, maybe in those very initial phases, and they put a 6 hours on it or whatever. Don't use it after 6 hours. And then they did admit that there wasn't enough studies. And most of them were animal studies where they looked at ice causing tissue regeneration. And there are no human studies. But let me make this clear. No human is going to volunteer to have their tibia smashed into pieces and their gastrocnemius ground up and then iced. And so we can then analyze the cellular component of it. We can't do these studies on humans. So we have to do them on our rat counterparts where we mitigate a crush injury, we mitigate a sprain strain injury, and then we look to see, and yes, where the rat then does get euthanized because we want to take out the tissue and look at it. And there's been plenty of studies that have shown that cooled tissue after acute injury does show better cellular migration and differentiation. We can't do that on humans, and nor will we ever be able to unless IRB changes. And I wouldn't want to do that study on humans anyways. We think about muscle biopsies, and that's probably the most severe form of really being able to like look at muscle tissue and analyze it for its protein content. And if you've ever had one, it hurts. Right. They take a little piece of muscle and they can nick a nerve and some other things. And so, we can't do those types of studies on humans. So to be asking for results that we can't really produce is a little bit outside of the norm for that.
Yeah, I love diving into the expertise here and also trying to pull away things that maybe support my own personal practices, and maybe for some of our listeners out there too, is there's an obvious science behind the research as to theoretically why modalities would work or could work or do work or don't work. There is science and legitimacy behind every angle of it. But there's also this art form of navigating that application process.
It's the art and the science.
Right. And it's that marriage between art and science, I think, that I've come to lean on as a practitioner a whole lot more later on than as opposed to when you're going through school. It's like, oh, ultrasound, it's ligament responds well to ultrasound, so I got to ultrasound the ligament. I think there's probably times in my career where I just haven't turned the ultrasound machine on because I know that like I've applied this probably too many times and it's probably doing nothing. So I'm just going to use it. I'm going to pretend to turn it on. I'm going to run it. I know that it's not on. And there's probably other times where I haven't known that I haven't turned it on, but I'm going to run it. But there's also a placebo effect to the application.
There's a placebo effect. It's your care, your time with the patient that can make a big difference. I mean, again, that's, and what led me to do my PhD and to work with Dr. Draper is, I was a clinician at Ithaca College, great Division III college up in upstate New York, and football and track and field were my main areas. And I found myself like doing ultrasound. And this was when all the research was coming out about how long you needed to do it if you wanted to heat it up, and making assumptions. Well, if I put it on pulsed, it won't heat. That's not true. It's all about energy delivered. And so you have to match, well, what is my therapeutic goal? Well, how much energy do I need to deliver? And some things respond to ultrasound that's more non-thermal, and other things respond to a thermal response to ultrasound. But also, I remember using ultrasound like on a whole entire shin, and nobody telling me, but
right.
And they're like, oh, by the way, it's about 2 to 3 times the head size if you want to actually accumulate energy and create heat. Now you can ultrasound a whole shin and you're going to have a non-thermal effect, and maybe that'll be helpful. But just these slight changes in characteristics that you don't have to use a modality, but if you are going to use a modality, I ask you, please, let's match it with with the pathology and your clinical goal, because you're definitely not going to get the result you want. If you wanted heating, you wanted to heat the tendon or ligament, and so you chose ultrasound, but you put it on such a low wattage and pulsed it and only did it for 3 minutes. You're not going to get what you want. So no wonder it didn't work. I mean, that's, Dr. Phil, despite some of the things he's done recently, always had that catchphrase. How's that working for you?
Right.
How's that working for you? not using ice. How's that working for you? Using ultrasound, always 5 minutes, always 1 watt. How's that work? Well, nobody's getting better. Well, does that mean that it's the ice's fault, or is it my fault? Like, that's something to consider a
Yeah.
little bit. And I do understand that time limitations really do prevent the use of modalities. And that's why many, many physical therapy clinics have moved very much away from the application of modalities, where you don't see, I mean, I broke my ankle this last August pretty decently. James knows about that. And I'm still just wrapping up therapy, but there's not a single modality machine sitting out in that PT facility. It's all exercise equipment, and then they're doing hands-on joint mobs and everything. There's a biodex back in a room. I would imagine they might have an ultrasound unit back in a room, so, like,
Right.
but best of my knowledge, I spend an hour there and doing my work, and I'm not seeing anybody getting a modality. Nobody walks out with a bag of ice either.
Hmm.
What are we
Yeah,
doing? What
yeah,
is it
it's
that, why are
interesting.
you handing him a bag of ice?
Yeah. You know what I could go for at the end of all this work? A nice bag of ice, right? Like this would be a thing that I
Yeah,
would be
and
purely comfortable with.
exactly. And is there anything wrong with that? Well, maybe not, but so I just pitched 8 innings. Do you think I should sit on the bench with an ice bag on my shoulder and elbow for 30 to 40 minutes? Does that make any sense in what we know about recovery? It doesn't make any sense to me.
Hmm.
I mean, didn't I? Yeah, I'm a little sore, I'm a little fatigued, but okay. I'm not saying don't I, but maybe 5 minutes of some ice, just to like get the edge off of just that achiness, relax some spasm that might have started up due to fatigability, and
Hmm.
then cool down.
Yep.
Yeah, yeah. Do some exercise, do some light banded exercise. Have somebody stretch you out. Um,
Yeah. Reverse,
do some other
undo some of the
recovery.
doing.
Yeah,
Yeah, exactly. Yeah.
yeah,
I think
yeah. I mean, again,
this,
not to say that that's wrong, but I think we just like everybody got a bag of ice when they were done with like a workout or why did you hurt them? I mean, and I'm sure we all have hurt somebody in therapy, and I mean that in great is like we pushed just 1 inch too far, kind of thing. And you're like, oh, okay, well now we know where your threshold is. So, all right, why don't we stop for today? Let's get a bag, let's
yep.
maybe prevent. But that's how you tear scar tissue to restore scar tissue, and that's a part of a process. But to assume that at the end of every therapy session, somebody should walk out with a bag of ice or sit for 20 minutes. And we did that. I remember doing that, and
Hmm.
there wasn't any question.
Yep. And then and
So
the pendulum tends to swing, I think, in the
yeah,
performance space in
swung
a
all the
therapeutic,
way to where
right?
they're.
So everybody needs ice to nobody needs ice, and there's no happy medium.
It's,
Like you have to be on one
I
side of
know
the
there's
fence
no
or the
happy
other, right?
medium, and it's like I'd love to bring back ice more than in my Sonic drink. If you
Yeah.
guys have Sonic up in Canada, or a slushy, it's like
Yeah.
because ice is an amazing pain reliever, and if pain is preventing me from moving, then I can't do my motion as lotion. And if I can't do my motion as lotion, I can't do my exercise, nor can I sleep if I'm in pain. And that doesn't mean that I should take an opioid to sleep. And that's where I have a personal opinion that if medical schools actually trained people on the proper use of ice and heat, and of course the pharmacy companies weren't being just horrible in their offering money and parties and and all the other things, then maybe we would have had better advice that, yeah, if you take a hot shower before you go to bed, or if you take a alternating hot and cold shower, that'll help your parasympathetic system.
Yeah. So
Yeah.
so I
Um,
don't need to find a frozen
yeah.
tundra in the Arctic and spend 3 weeks straight, you don't need to go
Yes.
overboard with this stuff. You need to find,
No.
what works, right?
We need
And
to
I
find
just
a happy medium of how you maybe can mitigate it, and that not everything works for everybody. Um, and that's a key thing is, there are no perfect therapeutic modalities. There's only patients. And there are no perfect protocols is another one of my sayings. There's only patients. Yeah, we
right.
have an ACL protocol, but we got to match it. to our patients. So, I mean, I think the biggest thing, and I pulled up a couple very recent research, because I just love, because every modality study will pretty much say this, and I'm just going to read it. It says, conclusions. Non-surgical modalities are low-cost treatment strategies. Yep. With rates of adverse outcomes as low as 0.008%. So these rarely, if ever, hurt people, unless you frostbite somebody with a blue cooler ice bag that's meant to chill your beer. And that are going to have different amounts of popularity, but there's a paucity of research, and high quality studies need to effectively evaluate these treatments so we can provide appropriate care. But here's the rub. Drug studies have placebos. Do modalities really have placebos? Well, I have used ultrasound in a study and not turned on the machine, and diathermy and not turned on the machine, and an electric stim study where we pretended to turn on the machine and told them it was microcurrent and they weren't going to feel the stim. You can't blind a person to heat or ice, can you?
Right.
You know whether they're getting heat or ice. I mean, and we also culturally have a connection with that of either liking ice or heat. And the same thing, you can't fake cup somebody. Well, I guess you could put a cup on somebody and not suction it. I mean, you could do different, if you're going to massage somebody, you could do different forces of massage, but not massaging, they're clearly not getting the treatment.
Right.
So you're not getting that taking the sugar pill kind of thing. So it's very hard to study design these. And another article that just recently came out from a manual therapy group talks about how hard it is to study manual therapy because of all the mechanistic factors related to the provider, how hard I push, whether I use my hands or a tool, the patient. I'm sure you've run into patients, as have I, that you can barely put any pressure and they're just in pain. And then there's others that they basically want your whole
Right.
body weight, like digging into them. And then there's lighting and music and whether they drank enough earlier that day and did they sleep. There's all these factors. And so it's really, really hard because context matters. So that's, a big piece of this. It's hard to study modalities. And so since it's hard to study modalities, the studies that do come out and that I've done are low-hanging fruit studies. They're just low-hanging fruit that I measure temperature because I really can't, and I can't, so I measure temperature and then I make an assumption that the next time I do this on a similarly sized person, I'm going to get the same temperature reduction. So then if I want to measure function and I get certain changes in function, then I can be, we know based on previous research that 20 minutes of diathermy can heat a muscle, to within 2 to 3 degrees. But let me tell you that in all the data and all the science, it does not matter what I do. When you've got 20 subjects and you cool them or you heat them, you're going to get responders and non-responders. It is so amazing. And that we end up taking this mean and saying that that's, the true population. And it's not, because there's some that super responded, got super hot with the same amount of treatment, or super cold. And then there's others that their body temperature didn't change at all. The muscle temperature didn't change at all. And so it's tough.
Yeah.
And that's an important factor.
And you're effectively validating the human component of the therapy relationship, right? Of the athletic trainer, that you need somebody there that can evaluate, what does this person need? What timing is this going to be most effective with this person? And it is a bit of trial and error. Like I talk about that openly now, but early on it was like, you have to know everything and you have to know what to do, but the more and more you do it, you're like, no, this is a bit of guesswork here. It's educated, but there's a whole lot of feeling out, a whole lot more leaning, I think, towards the art form of this and the application of this.
Absolutely.
As opposed to, hey, when you walk in, we're going to give you a heat pack because that saves me 10 minutes where I'm still thinking about what
10
I'm going to
minutes.
do. And right, like 10 minutes, the arbitrary amount of like, that's just what we're going to do with
Yeah.
everybody. It's
Oh, no, I
ubiquitous,
agree with that. Yeah.
whatever, right? All those types of things. So, but I think again, it comes down to, like you said, context matters, right? And understanding what the outcome target tissue is, what the pathology is, what the functional pathology is, what the modality has the
Yep.
potential to help with, right? And so
Right.
I don't want to keep you all day because I know we could, but if there's sort of like a recent modality that you've spent time analyzing, I mean, you don't have to go too far to look on social media. It was Wim Hof and deep ice submersion and whatever.
Yeah.
For a little while now, it's swung to red light therapy is everything. It's for
Yep.
bone, it's for
Yeah. Mito red
ligament, it's
light is
for
the big, yeah. Yeah, honestly, again, and this is just it, as it goes by Instagram and TikTok of where you get the most. And it seems like we have these swings. And yeah, at the last NATA conference, they had the red light beds and stuff. And I can remember when we were using light machines in 2004, and we used them for a couple of years, and then they just got put on the bottom shelf. And but again, maybe we weren't using them in the intensity that we needed to. So in my own research, I really think that we have neglected diathermy because it typically comes in, you think of the big, huge unit with the big old head, and it takes up a lot of space and it's got electromagnetic energy. So you got to be careful with pacemakers. But I've worked with a company who's trying to design a portable unit that a patient would buy and or rent. Much like you would rent a continuous ice cooling device, as opposed to buying like a game ready as a patient, because a lot of patients go home with a Breg or other continuous cooling device. But what it does is it takes heat deep. We have this layer called skin and subcutaneous adipose tissue, and that'll always prevent any superficial modality. So yes, rub all the capsaicin cream and all the biofreeze that you want on people, but that ain't getting deep, folks. It's causing a wonderful sensation on the skin, which may change the perception of pain, and everything, but it's not heating the muscle or cooling the muscle. So I'd really like to see them get FDA approval and see if it could get out into the public, because we know people are willing to buy these thousands of dollars red light. I mean, some of them are cheaper, but I'm telling you, if you buy a cheap red light, you're not getting what you're getting is a couple light bulbs that are tinted red. You're not
right.
getting,
Yeah.
the actual
But you are getting
LED,
the
super
placebo
LED.
effect of it for sure.
Yes,
Yeah.
exactly.
Yeah.
You're not
Belief is
getting the
power.
actual, super LED and LED on that wavelength spectrum that for those units that you do see are 1,000, and some odd dollars, that people are willing to pay for things that work. And I know that it leaves an elite class being able to access that, but I think we junked diathermy years ago because there was a scare. I know this. There was a scare that it caused miscarriages, which was all false. And then it's a pretty expensive unit, and it takes time. You do have to do it for 20 minutes, but this is where a home treatment might be helpful. That's not something that's going to be done in clinic. This goes home with the person. They can do it at night for 20 minutes, and then they can have a series of stretches and motion that they need to perform right after it. And then when they come in to see you, their tissue's in a better state with that. The other thing that's striking me too that I've been is electrical stim suits. Maybe you've seen, they look like triathlon suits, and they've got like 16 electrodes in them.
Yep.
They've had some pretty amazing, miraculous changes with individuals with MS and some other conditions that have caused, temporary paralysis or muscle disuse. And so I'm hoping to get to engage with them a little bit and see if it facilitates exercise, that the design is not that we're going to contract them and do Russian stim with that, but that it is providing a neurological boost and helping us to use our own neurological system better to activate our muscles in a more effective manner. Yeah. So
No, I
that's
love
kind
that.
of, yeah.
Yeah, I'm in that age bracket now where any social media that I get is geared towards dad bod. So it's not the tool
Oh
to like
yeah.
combat dad bod and turn me into a Navy SEAL looking type.
No,
Yeah.
yeah, turn it
Yeah.
into an electric stim never will be Bruce Lee and Rocky and his electrodes. That's not the role of electric stim. And yeah, don't get me going on how we've misused electric stim because here's just one piece. When you're using Russian and you want to get a quad contraction and it's killing the individual, it's causing them a lot of pain. You're not helping yourself. Pain inhibits muscle function. What are you doing?
It's,
It should be a comfortable muscle contraction.
this is the
Um,
science.
I don't know. Yeah, this is the science. You know, you might want to change your pads every now and then on your stim machine. Maybe each patient has their own set of pads and they use them for 5 times and then they get thrown away.
This is
No wonder you have to turn up the stim machine and put tape and pre-wrap around the pad. The pad doesn't work anymore. I mean, there's just some of these things that I'm just it's like
I can
we're
only
picking our
imagine yeah, doing the amount of research and study that you've done in depth and then seeing what's out there. Like I hit my head against the wall enough times throughout the course of a
yeah.
day, but
Well, I love
seeing
to go. Yeah, I love to go into the exhibit hall and go up to the modality dealers and try to have them tell me about my lactic acid crystals that their massager is breaking up in my tissue. I'm like, really? Tell me more about that.
yeah, I'm sold for sure.
Yeah,
No,
sold. My lactic acid crystal. Yes.
yeah, I think it's an amazing sort of capture to have somebody who's doing the work. Is there anywhere that you'd recommend sort of our listeners either to reach out to you or see some of your work or get a deeper understanding if they want to dive in? I can leave it in the notes if
Yeah,
you
I
want.
mean, I'm
But
always willing to speak to groups. I love this kind of contact, this little, like that I'll answer questions or I'll even present to your class. I oftentimes was brought in for other athletic training programs via Zoom to talk about, specific modalities and, to open up people's minds to that. I certainly, I don't have a consulting business right now, but that's, a thought process of how to do that. But I would always say that, it's hard to say where to go for the most appropriate research because if you look at all the appropriate research, it basically keeps saying there's not enough research to come to conclusions.
yeah.
But I will tell you this is that the absence of evidence, and this is important, this is Atul Gawande, who is a famous surgeon who's written a lot of books, is not the absence of evidence. So, um, uh, ultimately, if the study hasn't been done and there's not evidence, it doesn't mean that then it doesn't work. I mean, we have to understand that it's important that all these contextual factors matter. And in all the studies where they say that ice didn't have a beneficial effect, I tend to disagree. It certainly had no adverse effects, all right? And when this pendulum swang away from ice, nobody was dying from ice. Yes, you can frostbite yourself with ice, but you can frostbite yourself in a cryo chamber. You can burn yourself with a hot pack. I mean, let's just use our heads with this, all right? Um, and what it did have was what people were like, it wasn't statistically significant, but I want to emphasize, and you mentioned this before, but was it clinically meaningful? And I don't want to get into, well, it has to be statistically significant before it can be clinically meaningful. Ultimately, did your patient like it? And when they looked at some of these treatments for hip replacements and knee replacements where they used ice, they shortened their hospital stay by a day and shortened their pain med intake by 60%. Let me tell you, after 5 days in the hospital for this ankle that came out of my body, I would have taken less than 1 day in the hospital. I was bored as anything in there. And then when I got my bill, the 5 days was $164,000. Now I have insurance, and so my
Yeah.
part of that was obviously much less. But think about it. But I still would have paid if I'd had one less day in the hospital. And the same thing with, the use of opioids, like cutting down your pain meds because ice was used as an effective pain relieving modality. So don't throw the baby out with the bathwater. Is that something in Canada that it like that the baby was the last one to take the bath in the old time family and the bathwater was dirty by then. So you might forget that the baby was in the bathwater and throw out the bathwater. All right. Just because there's no evidence, the absence of evidence doesn't mean evidence of absence.
Yeah, this is
and keep
Dr.
being
Trowbridge
smart about your modality choice.
Yeah, well, we're gonna take all of this, I think, and myself included, and continue the discussion, obviously, in our circles.
Okay.
With our listeners. I hope people will reach out, and next time,
you can find me at University of Texas at Arlington. Yeah, if you go to uta.edu and type in Cindy Trowbridge, you'll it'll pop up and you can find out how to email me. I'm on LinkedIn, Facebook, lots of different ways you could probably get in touch with me. So
yeah, amazing. And recent inductee into the Southwest Athletic Trainers Association Hall of Fame just this past July. So congratulations again on that. Thank you so much.
Again. Yeah, that was quite an award. And I'm so proud to be there with a group of exceptional individuals. And have no intention of stopping.
Yeah, no, why would you? You're making such a difference here, and providing, realistic information, guidance for students currently at UTA, and then, our audience and abroad. And I hope that we can continue to grow this community, this connection. Absolutely. Next time we're going to dive in. Let's dive in on a couple specific modalities. We'll get a little bit of feedback here, and we can pick one or two and dive in on the realities, where they help, where they hinder, those types of things as a general capture today. Unreal. Really appreciate your time. Thank you again.
All right. You bet, James. Thank you. Love us. Okay.
Talk soon.
Take care, all.
Thanks again for being here. Thanks for listening. Thanks for being a part of this community. Check us out online, firststartherapy.com. That's FIRSTAR therapy.com. Or email us with feedback, consult@firststartherapy.com, consult@firststartherapy.com, on Instagram @firststar.therapy, and our podcast host @letschat.at. This is First Star Let's Chat, an athletic therapy podcast.